frankly, you feel like you've gone back to being a resident. Like, you're going to show up and you're not allowed to call in sick. And there's really no backup for a lot of what you're doing. Like, we don't really have like a call schedule or a Jeopardy schedule anymore. It's like you just work, you know. Who would find enjoyment in that kind of structure?
Welcome back to another episode of the podcast for doctors by doctors. I'm Dr. Michael Jerkins, and this is a very special day because it's not just me and it's not just the other host, it's us together. Do we want to reintroduce ourselves, or this is like maybe the first time in like a year?
I think we ought to, Michael.
Wait, what's your name?
I'm Dr. Ned Palmer, and I'm excited to be the co-host and interviewee of the podcast for Doctors by Doctors today.
Well, yeah. Well, it's kind of just a conversation. I guess in every conversation, there's someone that plays the part of interviewer and interviewee a little bit, if it's a good conversation at least. But yeah, it's exciting to be with you today. We have some topics we're going to cover. We do not have an amazing guest. We just have an amazing amount of topics to talk about today. So it's kind of this weird season. If you're not in healthcare, it's kind of hard to know like the calendar where we're at when we think about how doctors are thinking about jobs and how trainees are thinking about the next steps. But it's the fall, right? So it's really interesting because you have the medical students working on residency applications, thinking about the match, obviously, as always.
Probably interviewing already for some of them.
You got that. You got I don't know when this episode airs. So you have the fourth year dental students, vet students, you have the residents, you have the fellows that are all basically thinking about their job, their first job. They've hopefully interviewed or at least identified places they want to go. And then you have people that are already post-training, they're working and their contracts might be coming up to due in June or July or even May. And now is the time where they're starting to think, do I want to renew? Do I want to get a new job? Like, what am I even doing? All those kind of questions. So the fall, I think, is a good time to talk about the workforce, the doctor workforce, which is a big topic in general. And I want to bring it home, I think, a little bit to most people, even if they're not in healthcare listening to this, is recently I've had many conversations with folks on the frustration around having a new primary care provider or specialist. In fact, I have heard recently from someone in the last 12 months that they've stayed at the same office as a patient, but they've had 3 different primary care providers assigned to them in the last 12 months.
Oof.
Have you had this experience or know much about this as a inpatient doc?
As an inpatient doctor, I know this very limitedly, only frankly from being on the patient side, right? As we talk about all the time, like you and I are lucky enough to serve as doctors, but we're all patients. As a patient, basically every time I call in annually for my annual physical, I see somebody different. I don't experience any continuity. I see one of the largest health systems here in Michigan. I'm not going to name them in case we get into anything later that I need to. But I see one of the largest health systems in Michigan, and pretty much every year I see somebody else. So I understand the limited amount of continuity, even in the same office. I think 3 providers in a year is maybe in the upper decile of what I would expect, and really difficult then, especially as you layer on complexities or things about your history that you want somebody to know, or just frankly don't want to have to waste your time re-explaining every single time you go in there.
You think about doctor turnover, there's the patient side, which obviously stinks because you're having to explain everything again. Maybe the documentation by the previous provider wasn't great, so you have to ask questions they assume you already knew, which doesn't help with the continuity. And then, of course, rapport, it's another human being you're trying to talk about some of your most personal details of your life to. But then there's the health side, the actual health systems. If you're a clinic, if you're a health system, recruiting and finding a new doctor to come in that slot can run hundreds of thousands of dollars, depending on the specialist, even more potentially. And so I guess my question to you, Ned, given this duration of how long we're staying at jobs is shortening. In fact, I saw recently a stat for physicians in their first job. A majority are staying a little under 3 years in their first job. And that's kind of normal for those right out of training. Ned, let me just ask you straight up. Why do you think for a physician's first job, they're only staying 2 to 3 years?
For physicians only staying for their first 2 to 3 years, and this is going to be really heterogeneous between maybe some of our more procedural call cover, depending on what the nature of the job is. But I think about my own experiences where, as junior faculty and as a junior attending, I worked more than when I was a resident or a fellow. As a resident or as a fellow, you have federal work hour restrictions that you have to operate under. I think you and I know maybe there's a little bit of gray area there, certainly when we were residents, about getting or flirting with that line. Junior faculty and a lot of the junior faculty that I work with actually now had those all them kind of restrictions or handcuffs taken off, and so we're putting in more hours than they were as a resident, more time in the hospital, more time away from their families, worse call cover, worse call schedules, and this is all just kind of unfortunately in this nature of medicine of you're constantly like the junior most are constantly being asked to do the most to expand the coverage, and so I have to imagine that for a lot of these initial practicing doctors, like that very first experience is frankly more burnout, more exhaustion, more time away. Yeah, a couple of years later, you're going to be looking around and say, I've put 3 years in and nothing's really getting better. I just have to make a switch. I've got to make a jump. Now, my other thought on that would be, and I'm gonna botch this stat, so correct me if I'm way off base, but something like 70% of residents practice within like 50 miles of their residency program, something along those lines. There's a stat in there, but residents tend to take their first jobs pretty close to home, and it may be that they knew the facility, they knew the staff, they knew everybody else. And they may find out that geographically that's left them more limited and that there's better options out there. So I think it's a combination of excessive workload and maybe pretty narrow blinders initially. It's really hard to shop for a job when you're a resident, working 80 hours a week, interviewing, things like that. And so it may have given you a little bit of that push on one side of the job's not what you thought it was, and a pull on the other side of, kind of taking you out of that geographic region that you were set in initially. Maybe it's time to make some changes.
Do you think that most of the turnover for a doctor's first job is from what I heard you saying was more so on the scheduling side? Do you think burnout is, which is such a word that's overused and we hear it all the time and it's kind of somehow lost meaning a little bit? Do you think that's as much or greater of a factor than the schedule?
It's tough to talk about one without the other, right?
Yeah.
The world's best schedule could ameliorate burnout. The world's worst in an otherwise great job could make it terrible. Just the physiologic difference between day shift and night shift. So I think it's probably not burnout's pretty poorly defined. I think schedule is much more concrete. So I would lean on schedule just because it's a real tangible item. I think where a lot of that comes from is maybe people aren't aware of what the actual schedule is or look at it on paper and can't kind of extend to what that means in their life until you experience it.
What do you mean?
Like we often see, I've talked to a lot of physicians, and I'm sure you have, our social networks built with them, where they didn't realize what the call schedules they were signing up for. It says, oh, once a month, like one weekend call. Well, what does that mean? Is that Thursday to Monday? Is that Friday night until Sunday night? Is it, like a lot of people agree to certain things and take on certain responsibilities without necessarily what the mechanics are, right? Like weekends are defined quite variably depending on institution. My fiance works in healthcare. Her weekend, they consider Friday a weekend. And so anything after Thursday is technically a weekend. So if you're on weekend coverage, you could be on from Thursday at 5 p.m. until Monday at 6 a.m. That's a very different like call schedule or shift schedule than if you just told me, oh, I'm covering a weekend, right? That's like 50% more weekend you have to cover now. Like that can be crippling if you don't understand the details.
It sounds like what you're saying is that it would be really helpful for physicians to talk to an attorney to look at their contract as they sign, before they sign, even after they sign, to get an understanding of their schedule, which is apparently, this is per our conversation and a stat I just have, I'm gonna show you, is a big determiner of how satisfied they are in their job. I'm not sure if determiner is a word.
Determinant? I think you were so close. Could be. You're so close with determinant.
This is why I also need an attorney to help me just read my emails and my everyday conversations.
Yeah, yeah. It's the social determiners of health. I've always liked the social
That's
determiners of health.
exactly it. The Determiners might be a band name. Maybe that's what. Yeah, that's it. It's a band name. But seriously, this is why a contract review actually I think makes a lot of sense for doctors.
Yes.
I heard a story recently. This is a little bit of a tirade. It was a recent fellow who had graduated, and they were approached and they said, "Hey, did you have an attorney look at your contract?" And the fellow who was about to graduate said, "No, and the employer told me that they were giving me their best offer, so I didn't really feel like they could help me anyways." And it's not, it's like funny, but it's also sad, and like I'm frustrated that an employer would mislead, but it just speaks to the fact of just we aren't prepared and we don't know this space. And so if a big employer is like, "Hey, this is our best offer," like, okay, yep, they said it, so it has to be true. And what's interesting, you think about the stat again of 2 to 3 years of their first job. It makes sense, right? Because you also agree to a contract that you don't know, like you've never signed one before, you've never negotiated one before, you don't understand all the nuances, and so you get in 18 months, you're like, this isn't really what I thought, and now I know better. And so my second contract, I feel maybe more prepared to ask the right questions, or I better understand why an attorney could actually help me, because apparently like I'm super smart at being a physician, but maybe I'm not super smart at and capable or have the time to understand and negotiate my contract fully.
Completely. And I think the other thing that we see is from an employer side of things, you know, once they've got you locked in, they're unlikely to take that big step up to where, frankly, like you should be as a physician, right? So, and I think that is also a huge part of why so many people are turning over early. Even if they have that help and support, they're going to their employer and saying, "Look, like, this was written, it was a little unclear. You said it was your best offer, but I talked to the guy working next to me. He's making 30% more. Can I get an adjustment?" And oftentimes that answer is no. Like, from an employment standpoint, so many people are locked into little 3 or 5% changes based off what their initial contract is. And it means a lot of doctors then have to move or kind of make these bigger jumps away. So again, I think of this from like the push pull model. Like, it's just such a frustrating experience to land and realize what you've agreed to is not going to make you happy as a practitioner and as a provider.
But like you said, you haven't even been an attending yet, so it's kind of hard to understand what your day to day is like.
Yes.
And it is a little bit different because it is some parallel play. It's totally different than training, and you're in the thick of it with all of your colleagues.
You also get that offer, and I think it's important, like just from like the psychology of this, you're gonna be making $50,000, and in the middle of, let's say, rounds or some other like thankless, taskless month that you're working as a senior resident, you're gonna get a contract offer for multiples of what you're making on the day that you see that piece of paper. Like, there's absolutely a psychological moment of that where you go, "Oh my God, like I can finally eat. The stress is gone. I can make my car payments. I can consolidate all my bills." Like, and the employers know that. Like, they now have trained people in this to understand the psychology of these offers and to tune those levers down on you. They know that it's going to land, and you say, "Oh my God, this is 3 or 4 or 5 or 6 times what I'm making right now. Sign today." Just, I don't want any more. I just want to eat. Like, I'm starving. So they understand the psychology and frankly will use it against you, especially in that initial negotiation.
So there was a McKinsey analysis on this, and most doctors, when they talked about retention, what makes you stay in a job, 51% of the physicians said that schedule flexibility was like the key retention factor.
Is that one of the highest retention factors from that study?
That is one of the highest. Yes.
One of the highest. Yeah. Yeah. I completely believe that, right? Because, if you think of the corollary of schedule inflexibility, frankly, you feel like you've gone back to being a resident. Like, you're going to show up and you're not allowed to call in sick. And there's really no backup for a lot of what you're doing. Like, we don't really have like a call schedule or a Jeopardy schedule anymore. It's like you just work, you know? who would find enjoyment in that kind of structure of like, oh, thank you for telling me exactly when and where I need to be and giving me no flexibility.
I think about it from the primary care perspective, and we've all seen the studies of if a primary care doctor did all of the recommended screenings and counselings for every patient in their schedule, it would take them like 27 hours, I think, in a day.
In a day. Yeah.
And if you're a system, here's, and everyone listening that's in primary care understands, the system then says, well, you guys, you're losing us money. The primary care offices losing the system money, and you should feel lucky that we still even employ you guys. Like it's a favor we're doing for you. And keep in mind, they're not adding the revenue that your clinic generated for the system, for the tests you ordered, for the imaging that you ordered, for the referrals to the specialist, to all the surgeries and procedures and everything that happened downstream from you. They actually have to have you, but they don't show that. They don't attribute it to you. They just attribute the direct revenue from your own billings. And I'm like, man, you guys. So there's this aspect of you got to do more. Look, you're losing money, so you got to see more patients. Like we have to maintain profitability in your. They do this like fake.
Yeah, your fake divisional analysis. Yeah.
A doctor I work with calls it funny money. I think it's he's like, that's some funny money right there. It is. It's like you get a printout of your expenses and P&L, and like you're like, what is this number and where did this come from? And no one can actually answer it.
No.
They use that to then say you got to do more, you got to see more, you got to put in all the other stuff that Epic's flagging you have to do before you close a chart. And what is happening, especially in the primary care space, is that people are saying, I don't want to do this anymore. And many of them are exploring a direct primary care or concierge medicine type model. And for those who might not be familiar, this is probably going to be, someone's going to correct me on this, but basically direct primary care is a subscription-based model for primary care, but you also have actually subscription-based models for specialists as well. But essentially the patient pays a monthly fee. It might be something different if they buy for the whole year, depends on the model. And then you have access to your doctor. You can schedule kind of when you want to. You get more time, which then means for the doctor, that schedule flexibility is theirs. They're their own employer, right? They can also see and take as much time as they want to as their schedule allows them. They're the ones in control of the schedule for their patients. So I guess it's interesting, number one, to think about these market forces that are pushing doctors to say, I'm not doing this anymore. I'm going to go to my own model. But the other questions that come about are, what does that mean for patients at large who can't afford extra expenses per month for a subscription? They're just trying to make ends meet with their insurance premiums, or maybe they're on government insurance and they can't, they don't have disposable income. So I don't know, I just rambled there, but I feel like what we're seeing is this real big shift towards direct primary care.
Yeah, and this is an area that I approach very delicately as a hospitalist and not as an insider of the primary care world. But all the forces are there. I mean, even like going back to your very initial question, like what have we all experienced as patients recently, right? If you're not subscribed to, but if you're a primary care patient at a large health system, what have you experienced over the last 5 years? Have you gotten more time with your doctor? Have you gotten more personalization? Have you gotten a better, a provider that understands you better? No, I don't think any of those things are true. I think we've seen the visits go from 45 minutes to 30 to 25 to now 20, even for like routine or standard, like annual physicals and things like that. And it's very necessarily then scripted, scripted and proscriptive about just like making sure that they hit the high points because those are the big checkbox in Epic or Cerner or one of these other, billing softwares that masquerade as patient health records. And so, of course, like this entire class now of primary care providers has felt that push and has felt the quality they're able to deliver deteriorate, and they want those relationships coming back. I mean, I always wonder, like, do you have any stats on adoption from a patient side and how, like, I've seen patient satisfaction has certainly gone up, but in areas they're heavily subscribed, I'd just love to know what, if any, data exists on direct primary care and kind of like quality delivery, patient happiness, all of those things that they're should be bringing like in droves.
Let me first say the recent big beautiful bill, whatever you want to call it, has the ability for folks to use their HSA dollars to pay for direct primary care fees, which previously you could not use your HSA dollars. So in theory, the demand for this service is going to be higher because now people can have more affordability. I think with that, you're also seeing that employers are starting to partner with DPCs and send their employees to these DPCs, direct primary care, which there's some data that show that that lowers costs for the employers, which obviously then would accelerate how many employers and patients therefore would adopt this. So according to the Direct Primary Care Coalition, there's now 2,300 direct primary care practices in 48 states and reportedly provide care to 300,000 American patients.
It's pretty good.
Now, I've seen different numbers. It's a little bit, it's hard, I think, there's not one specific data point that I necessarily fully trust, but essentially a little over 2,000 is the number of direct primary care clinics. And then anywhere from 2 to 300,000 patients right now in the United States actually receive their primary care in this model.
Those are amazing stats. That's bigger than I think I thought it was, which is awesome to hear about the growth. And that is all of those numbers, of course, are before the biggest funding change that you just described as a result of the One Beautiful bill. I always think at the other end of the spectrum of, let's say, what's the quality delivered at your for-profit private equity owned institutions. And it seems like it's not a month that there's not some study coming out saying, representing a sharp decline in quality, an increase in morbidity, and an increase in mortality at, call it, the most corporatized healthcare delivery institutions. And so even just being kind of the opposite end of the spectrum from those things, like maybe it's still a little early to say the quality is there, but it feels like intuitively it will have to be there from the amount of time that can be spent, the amount of attention that can be spent, and frankly, individualization of healthcare, getting back to some individualized healthcare instead of, some of the cookbook medicine you're forced into practicing when it's all dictated by the electronic health record and a need to get these critical items done.
So let me ask this. So we've talked about workforce. We've talked about how it's affected outpatient doctors who are moving into this concierge or direct model. I think if you looked at inpatient doctors, as far as retention goes, my guess, and I think there is some data here that suggests that hospitalists have the highest turnover relative to most inpatient specialties. And then that's one. And then two is how many hospitalists eventually transition out of inpatient care altogether to an outpatient. Do you see much of that?
I do. I don't know the numbers. I apologize. And I'm not coming armed with data today. I see both of those things. I mean, the turnover, certainly I see a lot more than like people leaving and going to an outpatient type role. Just because obviously that's going to be way more prevalent. They're taking the same role at a different institution. And from a turnover standpoint, relative to other inpatient specialties, like hospitalists really don't have any follow-up. Even surgical subspecialties, if they see you for an acute care or surgical acute care hospitalization or something, they're probably still going to see you in follow-up, right? There's some continuity or a longitudinal relationship that you're having with that relationship. Hospitalists and hospital medicine are really interesting in that it's like almost purely episodic, much closer to emergency medicine in terms of like, this is it. This is the episode of care. I'm going to sign out to somebody else, and then we're going to pass it on. Like it's truly shift work, which I think makes people a lot more portable. I'd wonder about the relative changes between hospital medicine and emergency medicine. Then, like if hospital medicine is still changing locations more than emergency. Now in terms of the call it the mid-career change, if they go back in outpatient medicine, definitely happens. I've certainly had some colleagues do it. I've actually had a couple go into direct primary care, concierge care for similar reasons. Even from a hospital medicine standpoint, they were seeing 20, 22 patients a day on their census and were just feeling like the very same complaints or concerns from call it, your busy system outpatient practice. They just felt like they got no time with patients to do everything they needed to do. It would take them more than one calendar day to do it. And as a result, we're just like, I want any amount of control or leverage over my time, right? And my ability to practice medicine instead of just constantly feeling like you're having more and more patient stuff down your throat. Hospital medicine, very similar to primary care, loses money. Everybody will tell you that it's a loss leader in the hospital, that the division itself is not making any money. Of course, that's also funny money, right? Because they're not taking into account the exact same thing. Your referrals to other specialists, right? Especially, for complex hospitalist patients, you could have 3, 4, 5 referrals to that patient that they're not going to get subspecialty referrals for that patient that they're not going to get advanced imaging, obviously lab work, like none of that comes back and gets attributed. And so it's just purely, how much does the hospital get reimbursed for that bed? And does that pay enough for hospital medicine? So the same pushes and pressures are there for inpatient and outpatient. And so I'm not surprised that increasingly, if we see more hospitalists, frankly, leaving for a direct primary care model, um, where they can leverage that control back.
As far as the hospital medicine turnover annually, it's about 11%, anywhere from 8 to 10% annually. Compare that to all physicians, and that's around 7-ish percent. So it is higher, which makes sense, right? Again, like to what you just said.
Commoditized.
It's a little commoditized, but also, like you said, I mean, you go into it right early in your career and you're working holidays. You're working all the holidays. You're working the nights. You're working weekends. And so it's you eventually like, hey, I'm tired of this. Let me go somewhere else where my schedule, back to the schedule, is better.
Back to the schedule. It's also as somewhat of a shift work laborer, if you're willing to move for it, and a lot of residents are maybe younger, or not, I'm sorry, like early career attendings maybe are younger. If they have a family, it's a smaller family. They're willing to move for it, and it's relatively easy to pick up and do that. You're not having to wind down a patient panel or wind up a patient panel. You can show up, get trained on the EHR, clock in, and start working, which means you can shop for contracts, you can shop for compensation. And so maybe if you got the first one wrong, you're going to be more aggressive about saying, a year on, I'm going to keep evaluating this contract and seeing if there's something better for me. Because it's relatively easy to trade in and out.
There's an AMA survey that looked at doctors who were interested in leaving their job in the next 2 years, and they did it by specialty. And I have the top 10 lowest intent to leave and the top 10 doctors who are highest intent to leave. Do you have any guesses of the physician specialties with the highest intent to leave their job in the next 2 years?
Preventative care or public health?
Nope. Try again.
Maybe they're all already gone. Family medicine?
Nope.
All right. Are they specialists or generalists? Give me something here. I've not seen this one.
The number one physician specialty with the highest intent to leave the next 2 years is anesthesia. Number 2, vascular surgery. Rounding out the rest is radiology, general surgery, ENT, pulm, cardiology, psych, GI, and ophthalmology. You could guess this one, I bet. The physician specialty with the lowest intent to leave their job was what?
Pediatrics.
Dermatology.
Dermatology, interesting.
I feel like, I had the answers in front of me, but.
So what does leave their job, like change their job or leave their specialty?
Just to leave their current position, yeah.
Leave their current position. Okay, so derm gets in and stays. That's interesting.
Derm gets in and stays. Actually, you were right, though. Peds is number 3.
That one I felt better about on the less likely to leave their jobs. Like they're, again, patient panel, deep investment, longitudinal patients, all of those things. So that's interesting. That's a good one. I'm blown away by almost all of those were procedural specialties.
Yeah.
Except for psychiatry that wanted to change. Anesthesia at the top is always funny. I know it's kind of a running bit in medicine that anesthesiologists are the most entrepreneurial, the most business minded. So maybe they've kind of got that, understanding that by shopping around or jumping around, they've got more opportunities.
Maybe. I don't know the data on who works the most locums, but I would guess anesthesia has got to be one of the highest of those. But I don't know that for a fact. That's just me guessing. But Ned, we we have one last segment that I'm very excited about. This segment is called What Specialty Would They Be? And in this segment, I name a non-physician job, and you tell me what specialty you think they would be if they were a doctor.
Okay. I like this. This is by job, not by person, right?
By job. This is like the job, right? So first one is accountant. What physician specialty would an accountant most likely be?
Infectious disease.
Why?
Oh, it's the most forensic. I mean, right? Like, who else is going to go that deep into like, did you own a turtle when you were 6 years old, and can I get you a tax break for it? For your salmonellosis.
I thought nephrology.
I could see you on nephrology. I mean, it's very like I was thinking immediately you're most like numerical, objective based fact finding, and I was really thinking more of the accountants from like the deep dive that they take, which is infectious disease. I see nephrology though, very numbers based. Everything's a calculation of a calculation.
Next up, what physician specialty would they be? A school teacher.
I think pediatrics because of the patients,
I think you're right.
and I mean patients. NCE, not NTS, like with the patients that they have with everybody, right? Like having to work with families, realizing that the patient, is not just what's in front of you, just like the child's not the only thing important in teaching. It's, making sure that you're covering the entire family unit as well.
It also probably depends if you teach junior high or high school, adolescent medicine.
Of course. Yeah.
What physician specialty would they be? Next up is professional athlete.
Orthopedics.
Does it depend on a type of athlete? Like a long distance runner, you think they'll be ortho? You're thinking about like one of the big ones.
I'm thinking of a professional athlete. How many long distance runners are paid such that they have no other career in professional sport?
Actually, what's funny is on this podcast, I probably have interviewed like a lot of long distance runners and these ultra marathoners and
Yes.
And they all seem to be pediatricians, which is odd.
That is an odd that's a Venn diagram overlap I would not have expected. That's interesting. But I mean, look, back to it. Like you said, professional athlete, in my mind, I immediately jumped to, MLB, NFL, NHL, MLS, like all those, like it's ortho. I mean, I can't imagine anything else.
I think that's right. Next up, what physician specialty would they be? Sales.
I mean, it'd be the guy in the OR selling you striker equipment.
That doesn't count.
That doesn't count.
I know my answer.
I'm totally drawing a blank on this.
I'm saying urology.
Why urology?
I actually think urologists are the most entrepreneurial of all doctor specialties. Adult urologists specifically.
Interesting. Okay.
For those pediatric urologists that might be listening, not you guys, the adult ones. So that's my. If I have to pick, I'm not saying there's any one that really fits that, but that's my pick.
I was going to say transplant medicine because they are always trying to convince people.
That is true.
I was thinking purely from a sales standpoint. I get you on the entrepreneurial side of adult urologists and anesthesiologists. Yeah. Okay. Next.
What physician specialty would most likely fit a police officer?
General surgery.
General surgery? Why is that?
Have you ever been in an OR with a general surgeon? They are the law.
That is true.
It does not matter in those four walls. They are the law, and everything will be just so. Or you're going to med student jail, or some version.
I think that's actually pretty darn accurate.
What's yours?
I was gonna say like a surgical subspecialty. I didn't have one in particular.
Yeah.
What physician specialty would most attorneys fit in, you think?
Cardiology.
Really?
Yeah.
Not my answer, but why?
Have you ever given two cardiologists the same EKG and watched them come up with three different opinions on it? That I feel like is the absolute legal equivalent of if you ask two different lawyers the same question, you get 3 to 5 opinions. So that's my that's my feeling. What's yours?
I was gonna say internal medicine.
Yeah.
Overlap, obviously, with cards.
Heavy overlap, meaning they're just gonna argue and disagree with your points.
Well, just lots of questions. Not always are they necessarily valuable, but we like to talk. I'm an internist. I can say that. And also, my grandmother said I should have been an attorney. So maybe she said I argued a lot. So maybe that's why.
It stuck with you a bit.
It did. It stuck with me.
Grandma Jerkins really gotcha.
That's she was not a Jerkins.
Ah,
Last one. What physician specialty would they be? And that is, are you ready for this? Musician.
honestly, interestingly, I'm going to go back to the beginning and say nephrology. Some of the best musicians I've ever known were nephrologists, like medical musicians I've ever known were nephrologists. That's just probably my sample size.
I wonder why that is.
To me, it's that very like analytical framework and applying that to medicine. Pianists specifically.
They're supposed to be like the plastic surgeons and vascular surgeons because they're like their dexterity is amazing.
I'm telling you from my sample size, like some of the best, some of the best pianists that I've ever listened to and lucky enough to listen to in my entire life. 3 of them were nephrologists, which feels like enough to form a bias.
Wow, that is odd. Okay, maybe someone in the comments will educate us on why that is.
I've known plenty, like ENTs and others and procedural specialists who were excellent. I've got this from my own social network, of a consolidation around nephrology.
There you have it, folks. If you become a nephrologist, you are more likely to be a pianist, at least in the style of Dr. Palmer that he likes to listen to.
Classical pianist, of course.
All right, Ned, we always end this with the same question, but what is one thing you've changed your mind about recently?
One thing that I've changed my mind about recently is on new and novel treatments for COVID. I've actually been seeing a lot more of it and an uptick from a hospitalist standpoint. I frankly don't know what the data shows. We're listening to this during a government shutdown, which means our data is going to be even more limited in terms of what's coming next. But from a hospital medicine standpoint, over the last 3 months, we've seen kind of a sharp uptick in COVID specifically. And so we're having to, under these new regimes, kind of like monitor and evaluate treatments that we had used previously for their effectiveness. So, some of the basic things like dexamethasone and when and how are we using Paxlovid and inserting this into our treatment pathways. I think what is changing my mind is that I thought we'd established some of these things, and it's now I think we've gone back to an area of much more fluidity because they're not seemingly being as effective as we've understood them to be previously. So unfortunately, it's what I've changed my mind about is my confidence in some of our previously established pathways for treatment of inpatient acute and severe COVID.
That is a very substantive answer. I appreciate that. I appreciate you being here, Dr. Palmer, and a great discussion on doctors, and especially us as employees and how we work. And this really obviously matters to all of us as patients. I would love to hear feedback on some of these. What specialty would they be? Tell me where we're wrong. Thank you for joining us today on another episode of the podcast for Doctors by Doctors.
Thank you, Dr. Jerkins.
Thanks for joining us this episode, and you can catch the podcast for Doctors by Doctors on Apple, Spotify, YouTube, and all the other major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. To submit topic suggestions or guest suggestions or questions, you can reach us at podcast@panaceafinancial.com. As always, thanks for listening, and the next time you see a doctor, maybe you should prescribe them this podcast. See you next time.